right, good. All right, just want to make sure everyone. Hello? Okay, great. Good afternoon, good morning, and good night, everyone. Hello, welcome to the webinar on the journey to private sector engagement in Liberia. For those of you that don't know me, my name is Ryan Ubuntu Olson, and I'm a technical advisor with the Health Policy Plus projects funded by USAID. We apologize for our slight delayed start this morning. We're having a little technical difficulties, but we're excited for this presentation that we've been working really hard on for the past couple weeks and look forward to presenting it to all of you. I just wanted to open off with a few quick reminders in terms of this particular webinar. Just so you know, this webinar is being recorded and we will eventually post the recording to the HB Plus webinars page following this event. We would love to hear from you and we welcome your questions at any time. Please make sure you submit your questions via the question box on the in your webinar setup, and we'll probably get to those in our Q&A session at the end of this session. I wanted to make sure you all know, as we're experiencing right now, web conferencing platforms like this are getting an unusual amount of traffic, and thus we may experience additional technical difficulties. So if that does take place, please, we ask for your forgiveness. And finally, we ask that if you are happen to be unmuted or have your camera on, please mute yourself and turn off that camera. We have literally about 100 people expected to join today. We're so excited for all of you. So it'd be awful if we were interrupting each other. So please make sure you're mindful of that. Anyway, that concludes my particular announcements, and I'd love to now turn it over to my dear colleague, Anna Gerard, to help kick it off. Hello, Anna.
Hi, thanks, Ryan. Hello, everybody. Thanks for joining today's webinar. My name is Anna Gerard, Senior Technical Advisor for Private Health at Palladium, and I'll be leading today's webinar on the journey to private sector engagement in Liberia. Firstly, let me extend a warm welcome to our panelists today, namely Dr. Nicole Cooper, Clinical Director at Jamali Medical Solutions and Chair of the Healthcare Federation of Liberia, Dr. Amit Thacker, Executive Chairman of the Africa Health Business, and Dr. Kala Jabahau, who is the Director of Subsidy and Grants at the Ministry of Health of Liberia. Welcome all. So our agenda today will be as follows. First of all, I'll take a few minutes to provide some context for everyone. Health Policy Plus conducted a private sector assessment in mid-2019, and I can provide a brief overview of the findings, and this will help set the scene. Then I'll hand over to Amit, who will discuss the role of healthcare federations across Africa in private sector engagement. And following Amit will be Nicole, who will discuss the history of the federation, its current role in supporting the COVID-19 response effort, and the federation's overall private sector engagement objectives. And lastly, Dr. Jabahau will provide the perspective of the public sector with regards to private sector engagement. And we'll then have about 10 minutes, we hope, remaining for questions at the end. So as Ryan said, do place your questions in the box on the right. So firstly, as I mentioned, I'd like to provide some context, drawing from the findings of the Liberia Private Sector Assessment. Here, namely, I draw your attention to the importance of Monrovia as the capital city, given it's home to 1/3 of the population. This high concentration of people in the capital places high importance on the urban health system, which is actually where the majority of private facilities are also located. The population in Liberia is also very young. There's a high birth rate, with 70% of the population under 35 and only 7% of the population over the age of 55. Economically, the continual decline of the Liberian dollar against the US dollar has a significant impact on the cost of medicines, which are all largely imported and are all imported in US dollars. And at the time of the research for the assessment, the exchange rate was fluctuating daily. And I'll put a pin in that for now and come back to this point later. There are a couple of key policy documents that include references on engaging the private health sector. In response to the Ebola outbreak a number of years ago, the government of Liberia drafted the Investment Plan for Building a Resilient Health System. And this document sets out the importance of regulating the quality of care in the private service delivery sector, regular monitoring of private facilities, and the need for specialized trainings in Ebola management. But really, there are very limited references overall in other policy documents, and this may be due in part to the private health market remaining fairly small up until 2015. And you'll notice on your bottom right-hand side of your screen, the private sector made up only 2% of total health expenditure. In 2015, however, this figure jumped to 8%. Health Policy Plus was charged with conducting a private sector assessment to determine the current scale and scope of the private service delivery sector in Liberia, examining the enabling environment, as well as to identify practical opportunities to strengthen the private health sector. And there was a special focus on family planning. For this assessment, the private sector was defined as all non-governmental entities. As part of the primary research, 30 facilities were surveyed, which is about 10% of the total private market. A number of actors in the enabling environment were also surveyed: diagnostic labs, pharmaceutical companies, importers, distributors, and wholesalers, and private health insurance companies. What's more, a couple of years ago, the government of Liberia undertook a service availability and readiness assessment, and this also helped provide in-depth information on the private health sector. We also looked at the Malaria Indicator Survey, which provided information on antenatal care, family planning, labour and delivery. And I'll present some of this secondary data before moving on to the findings of the primary research. In terms of the size of the private sector, there are 258 functional private facilities. 73% is located in Montserrado County, which is where Monrovia, the capital, is located. Primary level facilities make up the lion's share of the private health market at 88% of all facilities. There are 16 health centres, which is 7%, and 12 hospitals, which is 5%. In terms of family planning in urban areas, as you can see, just over half of private facilities offer family planning services, and 27% of clients state that they access family planning services from the private sector. In terms of the distribution of equity across facility types, the private sector is on the right-hand side of the bar chart you see here, and is generally wealth quintiles 3 to 5, which is broadly defined as middle to upper class, that utilise the private sector for family planning. And now I'll show a short summary of the primary research findings from the assessment. In terms of owning a health facility, to obtain a health facility licence, the facility must have a licensed physician on staff. Any facility that is not actually owned by a physician, and that makes up 82% of those surveyed here, as shown in the bar chart, all need to have a physician on staff. And this regulation places a barrier on the growth of private service delivery, given that there are such a small number of total physicians available in the country. To start these businesses, everyone uses their own money, borrows funds from friends and family. Not one person surveyed got a formal loan to start up their business, and this is really indicative of the lack of availability of formal financing for the health sector. I'll cover just a few points about service provision here. There's a lot covered in the private sector assessment report, and I'd recommend you have a look there if you're interested in knowing more. There is very little diversification of service offerings among facilities in this area, and one informant actually remarked on this in the interview. In terms of the availability of family planning services, at this point in time in 2019, facilities receiving a free range of commodities from the public sector, which actually also included family planning commodities. They would receive a small stock every so often in exchange for submitting their health data on time. The condition was that they offer the services and product 100% free of charge to the client. And in a moment, I'll walk you through how that impacts the facility's bottom line. For commodities in general, overall, the private sector supply chain was working well at that time, and few facilities reported regular stockouts. There were, however, reports that indicated severely constrained cash flow, which was creating artificial stockouts of commodities. Anecdotally, one of the reasons cited was that this was due to the lack of reimbursements for services covered by private health insurance, and I'll come back to that point in a moment. In terms of trainings, there's very limited support offered to the private sector by way of external trainings, and in-service trainings in-house are quite limited. It was reported that the Ministry of Health hosts trainings 1 to 2 times a year, and some places are offered actually to the private sector. But the places were reported to be offered to facility owners at last minute, and it was quite difficult for them to arrange someone to attend always. Now, the availability of some services was also limited in some cases due to the lack of electricity, and this was quite a challenge at the time of the assessment. Most of those surveyed were operating almost fully off generators, and to get a sense of what this costs, for a one-story clinic with a small number of consultation rooms, the cost to operate a generator is estimated to be around $20 US a day. The last piece of information about health facilities which I'd like to show you today is on pricing. And in terms of consultation fees, so those fees that are paid upon registering or entering the facility, it's around $1 US for primary clinics, and 68% of primary facilities fall around this price. For secondary clinics, the price hovers around the same point. And for hospitals, it's around $5 to $10 US, and you'll note there's a very small sample of hospitals here, as there just aren't that many in Liberia. So if the private sector is regulated to provide services for free in some cases, as was the case at that point for family planning, this is the minimum gross revenue that they're going to forego when doing that. Now, moving on to private health insurance and coming back to that point, there are 18 companies who cover around 3% of the population, and they cover formal workers only. And as you recall before, I mentioned that facilities were citing that some private insurance companies were not reimbursing for service rendered for several months, and some really not at all. This was creating a financial strain on facilities who were still offering the services to clients because they had a valid insurance card. And what was heard at the time is that the premium holders, which were largely governmental organisations, were not paying for their premiums on time, and this had a knock-on effect which was being borne by facilities. Another part of the same story was also heard when surveying the pharmaceutical sector, and the market here is dominated by 3 larger pharmaceutical importers who are also wholesalers and retailers. There's no pharmaceutical manufacturing in Liberia, so everything is imported, and mostly in US dollars. So if you recall back to the earlier point around currency exchange fluctuations, you'll note that it means that a financial risk is placed on those within the supply chain if the exchange rate is fluctuating regularly. Those surveyed all really reported there were limited stockouts, as I mentioned before, and we were told that family planning commodities were generally not imported, as the government offers those services for free. They only really sold emergency contraception and condoms with regards to family planning. Malaria treatment, on the other hand, they do procure and consider the malaria market large enough for both free and paid commodities. Vaccines are also occasionally imported for the government, and this is on an on-demand basis when there are stockouts, and they only import a limited amount of stock for that particular situation. In terms of pricing, they reported adding a fixed markup as standard. There are fixed prices for clients with discounts offered for paying in cash, for example. Credit is offered pretty much as standard. There were some rumblings at the time about the knock-on effect of this cash flow issue at facility level. And one respondent here saying, and I quote, that customers are taking me as a financier. And at that time, some public hospitals were also still sourcing drugs from private pharmacies on credit, despite the relative inability to repay that sum. The last point I'll raise here, which is really related to private sector engagement, is aside from the public sector offering free commodities to the private sector, they were also offering annual subsidies and grants to a small number of private facilities. And how these facilities were selected at that point in time was unclear. At the start of the last financial year in September, this area was under review and was assigned to the Grants and Subsidies unit, which Dr. Jabahow on the panel today is going to talk about. Lastly, I'd like to quickly highlight a couple of the key recommendations that Health Policy Plus has been moving forwards this year. Firstly, one of the major points coming out of the assessment was the lack of any consolidating body for the private health sector. If the public sector wanted to engage the private sector, there was no, next slide, there was no focal point to actually engage, which makes it all the more difficult to start private sector engagement. Next slide. And in January of this year, the Healthcare Federation of Liberia was officially launched, and Nicole will talk to you more about this in a moment. The second point is that Health Policy Plus is currently supporting the Ministry of Health develop their first private sector engagement framework, which will help guide their approach to collaborating with the private health sector. And lastly, Health Policy Plus is also addressing the dire lack of access to finance for health businesses by providing technical assistance to a financial institution in Monrovia and, in parallel, strengthening financial literacy through targeted trainings for health facilities. And we're specifically targeting those wanting to access formal loans. And we hope that this will help businesses make those improvements needed to support their expansion efforts. And for those that want to know more, here's a link to the assessment, which is to be found on the Health Policy Plus website. And I look forward to answering your questions at the end of the webinar. Now over to Amit, who was going to talk to you more about the role of federations across Africa in private sector engagement. Over to you, Amit.
Thank you, Anna. And thank you to HP Plus, the Palladium Group, for giving me this opportunity to speak about the role of the private sector engagement and the role of the Private Healthcare Federation. I will move on. On the next slide, you will see, just like Anna outlined in the private sector assessment report, and some of her recommendation touched on a few challenges that the continent is facing. In a country of 55 countries with 1.2 billion people, in the last 2 decades, we have seen these 7 challenges to be cross-cutting and affecting almost the entire continent. We know that the private sector provision of healthcare on this continent versus public sector is almost at a 50-50 level. Some countries, we have a deeper private sector service provision than others. And the socioeconomic status of those seeking private sector tend to be in the higher quintile, but even the ones in the lower quintile do seek services from the private sector. Very briefly, leadership and partnerships have been weak and need to be strengthened. The second point is access to capital that Anna also mentioned. It's been pretty expensive to get capital injected into the healthcare sector. The third point is the regulatory environment has not been enabling, and absence of appropriate regulations have made investors shy away from driving greater funding into the sector. The fourth one is the disease burden, and also connected to that is the human resources for health, where we've had scanty health personnel dealing with all these high disease burdens that we face. Maternal and child mortality is a key aspect that many programs have been looking at innovations on how to manage that. Healthcare financing is a big topic, and under SDG 3 and the universal health coverage, we want to widen the safety net in Africa because out-of-pocket expenses remain a huge barrier in accessing these services. And finally, healthcare delivery infrastructure, and including technology and equipment, is subject to foreign exchange that also was mentioned earlier, and these global inputs become extremely expensive. So in my next slide, I'll talk a little bit about how we see the private sector federations coming together to find a solution for better healthcare. So in the last 14 years, there's been a movement, and almost 30 countries in Africa are adopting, creating a unified voice that Anna spoke about, that can continue engaging government in strengthening the health systems in country. What we have found is the private sector federations bring together in 3 categories almost everyone from urban and rural setup to be part of a unified voice known as a private healthcare federation, which you will hear more about from Nicole on how they managed to do that in Liberia. The Ministry of Health then has a single focal point. They can discuss regulations, they can discuss appropriate supply chain management, and they continuously have policies that will propel the growth of the private sector, moving it from maybe 8% like in Liberia and higher contributions to the total health expenditure. The federations then connect with also the other business councils so that they remain relevant in the macroeconomic framework, promoting affordable quality healthcare services across the whole sector. On my next slide, I'll tell you the importance of the private healthcare federations. And number one is pretty clear. I mean, we're much larger as private sector in Africa in health than we were, say, 30 years ago. So it's about time for the private sector federations to get organized and make a strong impact. The second one is the health sector reforms are top of the mind agenda for many ministries of health, and leveraging the private sector most effectively in country can improve health indicators. The third one, as we have heard earlier, is we need a unified focal point for the ministries of health to continuously engage. So we are trying to reduce the fragmented non-state health sector through a federation. And fourth is when we have a public-private dialogue, we build trust. And this trust is brought through an institutionalization partnership that federations form. In my next slide, I will talk to you about still some of the challenges that the private sector face. And those are the 6 challenges that you see on this particular slide. And very quickly, I already talked about the fragmentation. The second one is competition. There has been a feel of them and us between public and private. But through the public-private dialogue, trust is building up, and you're seen as a unified health system that's helping the country get much better, deliver growth, and deliver better health care. The third is, of course, the private sector has to look at sustainability, and if it doesn't get any subsidies, it has to focus on where it can receive revenue. This is the reason why they're more focused in the urban areas and not as much as we think they should be in the rural areas. It's a small market, and so we need to be innovative on how much we can expand the market. So regional economic communities like ECOWAS, EAC, and others tend to be very favorable discussions in the private sector. Low purchasing power is what's another challenge, because out-of-pocket expenses make it very difficult for many of these citizens to seek healthcare at private facilities, and therefore the need for national health insurance. And finally, limited infrastructure is continuously a challenge because it's very costly. In the next slide, the progress made across Africa is great. You can see so many countries since the year 2000 have taken on to this idea of forming a federation. Some of them are on early stages, some have incubated their federations really well. They have a continuous engagement with the Ministry of Health. They even present reports at the presidential roundtable like in Kenya. And since 2012, we've been forming a regional federation like the East Africa Healthcare Federation, and we've also got a West Africa Healthcare Federation. In the next slide, I'll just clarify what private sector actually means. When we refer to private sector in Africa, we refer to the non-state health actors. It's no longer about profit or not for profit, it's for impact. And if you look at this chart, it shows that the private sector organizations are actually active in all the 6 building blocks of WHO. This means that the private sector is playing a full, complete role in improving health across the continent. So what is the pathway? In my next slide, I'll talk to you about how does it work in a country. It's very simple. It's just, 5-step approach. We'd go in and find champions in the private sector, investors, hospital owners, people who own pharmacies or insurance companies, and then we bring those champions together. We go straight for a registration using the legal format in country. We try and include members from all aspects in healthcare and bring members also from outside the capital city. We design activities for that country, that speaks to its current needs, whether it's family planning, sexual reproductive health, or whether it's universal health coverage. And step 5 is to develop stronger partnerships. So this pathway has worked. So what is the advocacy platform? In my next slide. For greater coordination and partnership, these 5 key areas have worked really well, and the Ministers of Health has appreciated the advocacy and frank dialogue that the federations bring. They've also appreciated the governance, where we have members and all private sector organizations have a voice, they have a board, and they have transparency on how they keep priority engagements with the ministries of health. They set the stage and they give frank opinions on regulations that are hurting the private sector and what adjustments could be made to improve health. And finally, bridging the gap. And we help the Ministry of Health understand how the private sector operate. And through this, we also understand how the ministries of health operate, bringing the 2 entities together with greater trust. So let me give you an example of Liberia in my next slide when I talk about inclusivity. You will see on the left, when we talk about inclusivity, it's not a Liberia Private Healthcare Facilities Federation, but it brings in medical equipment providers, hospitals, insurance, and all those into one unified umbrella body that then reports into the regional federation known as the West Africa Private Healthcare Federation, who then reports at the Africa Healthcare Federation, comprised of the 5 regions. This makes it easier for sharing best practices, changing regional regulations, and promoting greater coordination. In my next slide, you will see that some of the countries that I mentioned, approximately 30 countries, have formed a federation. The private sector has divided itself in a regional manner to take advantage of the regional economic communities like ECOWAS, EAC, to drive a larger market, to drive down the costs of healthcare, but improve its quality. We have a connection with Africa Union as well as World Health Organization, and it seems to be moving well. In my next slide, which I will use to conclude, let me just show you some accomplishments of the Africa Healthcare Federation. Through this model over the last 14 years, we've been able to filter down some financial incentives that have brought the footprint of private sector to increase in country. We've been able to harmonize tax and remove unnecessary costs. At regional level, we have advocated for free movement of healthcare personnel, doctors, nurses, pharmacists between countries. Example, between Rwanda and Uganda, there is no longer a work permit required, which used to be $4,000 for 2 years, therefore driving down costs. We've also been able at regional level to sort of harmonize the taxes and pre-verification fees of medicines like paracetamol and antibiotics crossing borders to reduce counterfeit and fake medicines being shuttled from country to country. Now at the continental level, we have started building great trust with ministries of health, AU, and others through this organized public-private dialogue. And finally, the knowledge sharing platform has been immense, such as this webinar. But we have a long way to go. And now I hand it over back to Nicole, who will tell you a little bit about the journey in Liberia. Thank you.
Hi, everyone. My name is Dr. Nicole Cooper. As Amit mentioned, I am the clinical director at Chamale Medical Solutions in Monrovia, Liberia, and I'm also the chairperson of the Healthcare Federation of Liberia. I guess you could say that HFL then is the next case study that we'll be moving into. So next slide, I will just go into that now. As Amit mentioned, the healthcare federations are unifying voices for the private health sector. And as over the course of 2019 in Liberia, various institutions in the private health sector held organizational meetings, and eventually with foundational support from USAID through the implementing partner HP+, who has also brought us here today, and several local sponsors, HFL was able to have an official launch in January of 2020, with our first annual general meeting held shortly thereafter in February 2020, and the election of a 7-member board of directors and the establishment of our internal committees to address each of our following focus areas that you see listed here, which are public sector advocacy, public-private partnerships for health, access to finance for facilities, grouped procurement and supply chain, and standards and accreditation within our facilities. We really work together on these focus areas, as Amit mentioned earlier, with the goal of creating an enabling environment that will lead to increased access to high quality private healthcare. Next slide. So immediately after that first annual general meeting, we presented our credentials here in this picture to Honorable Dr. Wilhelmina Jalla, the Minister of Health of the Republic of Liberia, and had our first ministerial stakeholder forum. Dr. Jalla has been a strong supporter of the HFL during the entire inception process, and at this first official meeting, we signed a memorandum of cooperation, and the Minister of Health also designated a private sector liaison, that is the Deputy Minister for Administration, Honorable Noel Howard, as well as Dr. Kula Jaber Howe, who is on this call today with us. Federation Ministerial Forum stakeholder forums are a critical part of our work because they are the regular scheduled meetings that we, the private sector representatives, have, and we use them to engage the Ministry of Health around topics of mutual concern between the private health sector and the health sector in general, as well as potential areas of collaboration. Next slide. So from that point on, February 2020, you could say that HFL has undergone a baptism of fire. And this is just a brief timeline of what happened next. So January, HFL was launched with our official recognition. February, immediately after, or I would say around that ministerial stakeholder forum, the government of Liberia initiated its own COVID-19 preparedness response, or preparedness efforts, I should say. At that time, we had no cases. HFL was immediately invited to participate as a private sector counterpart to the Ministry of Health. In March 2020, despite intense traveler screening and despite mandated quarantining of travelers arriving in Liberia, Liberia recorded its first case of COVID-19. Immediately thereafter, preparedness efforts gave way to response efforts, and the Private Sector Engagement Committee at the Ministry of Health, which Dr. Jaber will speak about more, was revived. This committee had co-leadership by the Healthcare Federation of Liberia, the Liberia Business Association, and the Liberia Chamber of Commerce. Next slide. So since the initial invitation to the Healthcare Federation to join the incident management system, we have now solidified that to a permanent seat at that meeting. We began with this initial advisory liaison role between the private health sector and the larger national COVID-19 meeting, but with the launch of the Private Sector Engagement Committee, HFL has become a lot more entrenched into the specific technical pillars that are happening within the COVID-19 response, most especially around case management and how COVID-19 cases are being treated, infection prevention and control, risk communications, both within the response and to the general public, the laboratory pillar, and then logistics through the newly established Executive Committee on Coronavirus. Next slide. Regarding infection prevention and control, one of the first forays for HFL into COVID-19 actual project work was around IPC. Very early on, it became clear that there was a trend of healthcare worker infections in the private sector, immediately starting with the first 5 cases. Within the first 5 or 6 cases, we already had healthcare worker infections happening. This was for 2 reasons. The primary reason was that private healthcare facilities are where COVID-19 patients were showing up. And that being combined with a lack of adequate IPC training or infection prevention control training was leading immediately to healthcare worker infections. The government raised an alarm and a call for training of private facilities, but at the time was not yet prepared to launch that training. So HFL stepped into the gap. We adapted WHO modules for infection prevention and control to our local context. We set them to audio lectures, and we offered online virtual training in infection prevention and control that was suited to the Liberian context. We quickly then expanded those online trainings into in-person virtual training rooms that have limited capacity but offer access to tablets and Wi-Fi through support with the local Orange telecom company and through GIZ. Dr. Jabe, one of our public sector liaisons, actually lent her voice to one of the lectures as a voiceover. So that was a great piece of public-private collaboration right there. Now, 3 months in, we are currently looking to adapt this virtual training format to meet the new national training format that has been completed for IPC training nationwide. So this same format is now going to be used to deliver the content that the government has developed. So the collaboration continues. We've also worked with a partner of ours, Teach for Liberia, which is in collaboration with Teach for All, Teach for America, and the others around the world to provide food support for families of affected healthcare workers. They had initially started with a program around food support for their students, and then we collaborated with them to provide food support for healthcare workers, which actually extended beyond our private healthcare members to the staff of even the National Referral Hospital, which is a JFK Medical Center, the Liberian Association of Medical and Laboratory Technologists, which had several technologists who worked in the National Reference Lab who also were affected and became infected, and through the Liberian Medical and Dental Association, who keeps track of and has a welfare committee to keep track of all the affected healthcare workers. We've worked to disseminate official updates from the National Public Health Institute of Liberia when they are available. Even when they are not available, though, through our access to the incident management system, we're able to create updates that keep the general public and our membership up to date with the most recent numbers, healthcare worker infections and whatnot. And we also have started to have awareness campaigns just in general around how to protect yourself, effective use of masks, and the infectivity of COVID. Especially here, you see one of the posters that was made with one of our partners, LIB Healthline, that just shows a general infectivity of using things like public transport. Next slide. Around case management and the laboratory pillar, we have done quite a bit of technical advisory work there, from management of isolation and treatment units to helping with the validation of the national treatment guidelines, helping with the creation of traveler isolation and screening protocols for the reopening of the airport, and around the use of rapid testing and around the establishment of lab facilities even within those treatment units. Here you see a picture of one of our low acuity treatment units as it was being finalized. So in summary, that you could say Liberia's case study in public-private cooperation or private sector engagement through the Healthcare Federation has definitely been a partnership that was forged in fire. Right after our inception, we were thrown into a collaboration that has really worked out very well. And I definitely see it moving forward in multiple other areas after coronavirus has left us. I will now hand over to my colleague from the Ministry of Health, Dr. Kula Jabehal, who will talk more about that private sector engagement committee through the Ministry of Health. Thank you.
So I'm Dr. Kula Jabehal from the Ministry of Health, and I'm going to speak a little bit more on the private sector engagement in Liberia and also during the COVID response. Next slide. Liberia has a long history of public-private partnership. And it all started during the Civil War. We also saw that during the Ebola, and also we are now seeing it during the COVID response. At first, it started as a means of subsidizing health facilities, private sectors to amend the strength of government. So the government supported organizations that were delivering services in health and education out of the different ministries. Due to the Ebola, Liberia developed a national health plan and strategy. In that document, it also outlined the importance of the public-private partnership, recognizing the critical roles that private sector play in providing services in areas where government is unable to reach. For example, the malaria control used the private sector to increase the uptake of ACTs, which is artemisinin combination therapy that were used to treat malaria in Liberia. We also had the ministry through the Family Health Division using the private facilities to increase uptake of family planning. And we also recognize the importance of the private sector engagement group during Ebola response, which has manifested itself as also during this COVID response. That group was a multi-sectorial group that was made of private healthcare business communities, GSM Global, GSM companies, banking institutions, also cross-sections that were helping to strengthen the capacity of the Ministry of Health. How did that happen? During the Ebola response, all of the public facilities were closed out of fear of contracting the Ebola virus. And during that, only private facilities were open that were serving the population. Recognizing the importance of those private facilities, government then thought to subsidize them to also help to treat the vulnerable groups, especially women and children during that response. Next slide. Because of what happened, Liberia built a serious resilience and have now able to respond to other outbreaks. And so when COVID pandemic erupted, Liberia was kind of prepared and they knew the importance of the private sector. And I don't want to go into the history, but we know that in Liberia we have a first case, March 16, and that initiated an incident management team that was set up, of which gave rise to the private sector engagement committee that we are now part of. Next slide. And what was the goal of that private sector engagement during the COVID? Actually, it was to strengthen partnership with the private sector in planning, in mobilization, and in coordination that will lead to sustainability and effectiveness of the resources, especially for healthcare emergencies, including COVID. So this private sector engagement has helped us a lot. And we know we are now reaping the benefits, and we know how much they have done into this response. Next slide. As you can see, this is private sector engagement that was reestablished. And immediately when IMS established this group, we have all of these partners coming on board. We have Healthcare Federation, the Liberia Chamber of Commerce, and all of the different private benefactors. And the big business association, including the concession areas, are now on board during the COVID response. They are making the strength of the National Public Health Institute of Liberia and the Ministry of Health. Next slide. And so what is this private sector engagement group is doing. They have been working jointly with the Ministry of Health, the National Public Health Institute, and of course the Montserrado County Health Team that has most of these cases, and this is where most of the population, over 1.7 million population out of 4.8 million live, Montserrado County, which is the heart of the government, the seat of the government of Liberia. Next slide. Since the establishment, there were some objectives in mind for the establishment of the private sector engagement group. First of all, we wanted to create an enabling environment to support the response. We wanted to get all hands on top. We wanted to make sure that everyone, whether you were public, you were private, you were involved in this response. And we also needed to leverage the expertise to save lives. The private sector has a lot of expertise. As you can see with the response, they have been able to mobilize, they have connections and all of that. And so that was one of the core objectives of the engagement of the private sector during this response. And also to ensure transparency and accountability. We know that there were apprehensions, there were mistrusts, and so we felt that getting all private sectors on board, we will be able, and also using them to help the ministry to account for whatever that was brought in to assist the response. Next slide. What have they done so far during the COVID response? As Nico mentioned, they have provided a lot, very extensive technical assistance, development of standard operating procedures. They have also participated in the development of database and all of that that we did not have the technical expertise to undertake. The private sector has also expanded our ambulance fleet. For example, the Red Cross that have undertaken due to our low resources, our lack of funding to fund all of the different components of the COVID response. They have also participated in the construction of a triage, especially the 14 military hospital where we are treating most of our COVID victims. And they have augmented the strength of the public health sector by supplying donations in kind of medicine, medical supplies, IPC materials, and just to name a lot. Next slide. They have also developed a page for the private sector response. As you can see, you can log into that and know exactly what is happening. They also have a donation platform that accounts for all of the donations that I receive on a daily basis. And once you log in onto that donation website, you'll be able to know on a daily basis who brought what in to assist with the response. They are reimbursing private health sector for services rendered, especially the West African platform that is used to respond to the COVID, that is referred to as WASCOM. Next slide. We have had some challenges during our engagement with the private sector. And as we well know, there are policy challenges. The private sector has their own methods of working, and the government has their own standards. And so to ensure that to ensure equity among all actors, we need to have the private sector on board, at least initially from the beginning of planning, to help with the national response. Also in the Ministry of Health, we have had vertical policy making issues, and that was clearly visible during the COVID response, where we had non-health and health actors playing the various roles. So each one had their own ideas, each one had a new path, their own path, and how to look at how the response will be carried on. And resource allocation, there was some hesitation of private sector. For example, they were unclear how government were using the resources that were being brought in and how they could benefit, and also how those resources would be accounted for. And of course, the apprehension. Some, due to fearing for themselves, their fear was, how long is this pandemic going to last if I'm going to contribute? And what am I going to gain? But notwithstanding, we needed all hands on deck. But not all of the private sectors were able to come on board due to their own fear of the unknown. And of course, as I mentioned, the accountability of resources. And if it was not accounted for, we're actually going to have some issues and how it was going to impact the public health response. Accountability also led to transparency challenges. How could we at the Ministry of Health track and account for all donations, not only for COVID, but also any other donations that will also come pre, post, or intra-COVID response. We also had challenges with financial management. Government had issues with inconsistent and delayed funding. And so we needed the private sector to step in at some point because government had to mobilize resources internally, unlike the Ebola where Liberia was being assisted by all of the countries around the world. But this time, Liberia had to fend for herself. And so as a result, raising funds in country was very difficult, and we also needed to respond to the COVID response urgently and needed, and then at that point we had to have the private sector step in, but again, they were kind of concerned about the financial management of whatever was coming in. Next slide. Of course, we learned a lot of lessons with our public-private partnership through the private sector engagement. We know that when there's an established mechanism, we often get all hands on deck. So there was an established mechanism already, and the private sector was easily capable to fit in. And we know that with policies coming up, established already, we know that they will also fit in very easily. Alignment and collaboration with government's efforts. Government will learn the importance of public-private partnership through the private sector engagement. They have augmented the strength of government, and this has led to better outcomes during this response. Transparency and accountability was a challenge, but with the private sector being more engaged, it has built trust and has paved way for future engagement. They have found permanent solutions from this emergency response. Align motivation. We know that private sector brings a lot of benefits to the health sector, not only during response, but also post-response, and that we learned during the Ebola. After the response, there were a lot of capacity building, there were a lot of resources that were left over, and that the revolving system was able to use. So instead of beginning from scratch during the Ebola response, there were a lot of PPEs, a lot of IPC materials left over that is now being used for the response. So private sector engagement does not only stop during the outbreak, but it also leads to other better outcomes, even post-response. So these are our partners during the response who are still here. There are more. We have ArcelorMittal, we have Liberia Business Association, we have the radio stations who are carrying advocacy, and of course our Health Federation. We have Mwentana, which is helping with the database to track all donations, and a lot more who do not have the pictorial symbol of them here present. Thank you. And now turn this over to Ryan.
Thank you so much, Dr. Jabe. And given time, folks, we're going to take about 2 questions, and then I'll offer on a final comment. So thank you for those of you who are holding on so far. So Amit, your question is, how is the reimbursement for private sector services determined?
Yeah, that's a good question. It varies from country to country, and it also varies from insurance and health systems from country to country. Usually they do a sort of a costing study. What they find is customary and reasonable, then that reimbursement model is negotiated. And what's been the struggle is to look at the X base level reimbursement by government, and then finding a top-up charge that the clients can pay to access private services, simply because since the input costs of human resources and others in private sector are self-funded as opposed to government, the actual cost to the client will be separate. So reimbursement models are based on a costing study and an estimated contractual value of services to the private sector by government insurance schemes.
Thank you so much, Amit. And Dr. Cooper, we have a question for you. How can we enhance performance of faith-based organization hospitals in the midst of high competition? What is the role of faith-based health facilities in the Africa Healthcare Federation?
So there is a huge role, first of all, for faith-based healthcare organizations, because the healthcare federations represent all private sector players in the health space. So all non-state actors, and that includes faith-based. And we do have faith-based members, even in the Healthcare Federation of Liberia, as new as we are. And in terms of, excuse me, in terms of how do we improve their performance, I think Liberia, and Dr. Jabe may be able to speak a little bit about this, but Liberia has a very interesting model for performance-based financing that is used not only with some faith-based facilities, but also with some private sector facilities in general. Especially, as Dr. Jabe mentioned, private sector engagement dates back in Liberia to Civil War times, and then during Ebola and even post-Ebola, where there were times when the Ministry of Health did not have the resources to run even its own facilities at times, and those facilities were then subcontracted out to private entities, either NGOs or FBOs. So that was one way that the FBOs stepped in to actually collaborate with the public sector. And then their funding, or part of their funding, sort of the incentive-based funding, was performance-based. So performance-based financing is definitely one strong way to improve the performance of those faith-based organizations. And I'm not sure if Dr. Jabe would like to add anything, but she may be able to expand on that a little bit more.
Dr. Jabe, would you like to expand on that?
Yes, the faith-based organizations, like Nico mentioned, they are very important especially in our sector here. The bulk of our health facilities are run by either the Catholic or the ELBA hospital, or they are run by the Seventh-day Adventists. And so if you look at our big hospitals, besides the JFK Medical Center and the county hospitals, the big hospitals in Monrovia are run by faith-based. And so engaging them over the time, We know that they have supported us on a long way, and we know very well that government tried to amend their strength. Like, for example, ELB and Cali Hospital have been subsidized since the war through subsidies provided by government to amend their strength, because if there is any problem in the public facilities, all of the population run to the private facilities. And so government has not been able to subsidize them to help deal with half of the population in Liberia, and also to reduce prices for them. And so we have a good relationship with the private sector, especially with the organizations in Monrovia, in Liberia. Thank you.
Thank you, Dr. Jabe. Well, I'm going to summarize our last two questions for you, Dr. Nicole, not Dr. Cooper. And that is, how do we ensure that resources allocated to the private sector are put to effective use? And what criteria do we use to evaluate which private sector hospitals are utilized? Our final question.
So first of all, how do we make sure that resources allocated to the private sector are put to good use? I think I'll refer back to the same performance-based financing model, because they have a whole list of criteria and accountability monitoring structures that have to be followed. Once you're receiving funding, you must meet these criteria. There will be a review. There will be a monitoring team that comes every so often to make sure that X, Y, and Z is in place. And we are expecting to see the following results. So if we are financing, for example, a private facility around maternal child health, we expect to see differences in outcome in that catchment area for maternal child health before and after. So I think the answer of how do you make sure that the resources are being used effectively, it's not through, for example, auditing the books. It's through looking at the outcomes. Are the outcomes being achieved? So that is the primary way you do that.
Thank you so much. Well, thank you everyone to the 100+ people that attended today's webinar. Again, this will be recorded and posted online, so we thank you for your participation. I want to hand it over to my dear colleague, Anna Gerard, to just offer final comments on today's webinar. Thank you.
Thanks, Ryan. I hope that whetted your appetite for private sector engagement in Liberia. And as we move forwards with this beyond COVID-19, we'll keep you informed as to the progress we will make. I just want to say thanks to everyone online for joining, and apologies for running over a little bit. And thanks to our panelists for their time today. Thanks so much.
All right, everyone, have a wonderful rest of your day, evening, and night. Take care.